our department of plastic surgery in Belvici.
Yeah, hello
And
everybody.
yeah, thank you for being
I
with
don't
us
see
today.
Anna, but send my regards to her.
Yeah,
Okay.
it's in the bottom, yeah.
Okay.
Yes, thank you for being with us today. We know you have a busy schedule. You are I think in Germany, maybe doing a course.
Yeah,
or
in Holland.
In Holland. Okay.
Yeah, Holland.
So
Yes.
we won't steal you too much time. This is a monographic session about lymphedema surgery, and here to open the session we have Dr. Giuseppe Visconti, who will talk about LBA and ultrasound. Dr. Visconti is one of the leading experts worldwide in the field of LBA planning with ultrasound, and he developed most of his skill set and expertise in Tokyo, working with Professor Koshima and Dr. Kitatsu Hayashi. Now he's an attending surgeon at the Policlinico Gemelli in Rome. Again, it is an honor to have you today. So whenever you're ready.
Yes.
Please.
Yes. Thank you very much for your kind invitation. It's a big pleasure and honor for me also to stay with you. And so if you allow me to share the screen, I can.
So we're trying.
Yes.
¿Dónde es? ¿Sabéis hacerlo? Maybe now, maybe?
Yeah.
Okay.
Okay, can you see?
Yes, we can see. Yeah.
Okay. So today I will talk about the use of ultrasound in lymphatic surgery. Thank you again very much for your invitation. And so I work in Rome at the Policlinico Gemelli hospital. So if we think about lymphatic surgery and we go to the lymphatic venous anastomosis, we know that this is a very easy concept. It's a physiological procedure with diversion of lymph flow toward the blood circulation, and the aim is to bypass the channels into subdermal venules. But how to perform LVA? So not any lymphatic channel is efficient in obtaining consistent result. Also, not any subdermal venule is effective for obtaining consistent result. And the bypass has two independent components. One is lymphatic channels and one is the subdermal venule. So the recipient venule is a very important topic in lymphatic venous anastomosis, and we should select the best vein as our recipient vein in LVA, and this should be not a secondary things to do, because we can select our recipient vein, and we found, according to our study, that actually the recipient venule as an independent factor on the composite outcome of lymphatic venous anastomosis. And what we want to have when we do lymphatic venous anastomosis, we want to see a clear, expanded, lymph-expanded, more fluorescent vein. It means that we established a good anastomosis with a positive gradient from the lymphatic channel to the vein. And this will give us the good clinical results. So lymphatic channels, of course, this is what we have, because lymphedema is usually is related to a degeneration of lymphatic channel. Then, of course, we have different stages, but the key is the ability to locate large and good lymphatic channel in the affected limb. So lymphoscintigraphy and ICG lymphography may help in visualizing lymphatic channel, but what to do in dermal backflow area and what to do in area where the pannus is thicker or in patient with more advanced lymphedema. So the aim here is not to offer LVA only to subclinical and moderate stage, but also for advanced stage, if possible. So how to know that? By using the ultrasound. So we found that ultrasound is actually a very powerful tool that we can have in our hands, because for many plastic surgery application, from basic and general plastic surgery to more finesse things, even in visualizing lymphatic channel. So lymphatic channel, they have some kind of peculiar images. They are homogeneous, hypoechoic, with the specular misshapen image, and they usually have a hyperechoic wall. And they should be differentiated by blood vessel. Blood vessel usually have a color Doppler signal the lymphatic channel doesn't have, but also from cutaneous nerve. And these can be differentiated by following the lymphatic channel, and also by finding a not specular misshaping image. And also because with cutaneous nerve, you sometimes can count the fascicles. So the very nice application of ultrasound is not only for linear patterns, so you can have more information even if you have linear pattern that you find with ICG lymphography, but also to visualize things that you cannot visualize with ICG lymphography, like in dermablock area. Like in this case, you can see this is a forearm. The patient didn't have a linear pattern in this area. We had direct diffusion of the indocyanine green into the subdermal plexus. So when you have this kind of image at ICG lymphography, you cannot plan your LVA. You even don't know if there are or there are not lymphatic channels. You don't know how many you will have. You have no information. So you may do, let's say, a casual cut, but casual cut means that you don't know what you are doing. So you don't know what you are offering to your patient. But if you go with the ultrasound, like in this case, we can select and find the lymphatic channel and the vein. So, but besides the topographic location and the findings, we perform a study with comparing ultra frequency ultrasound images and histologic images, because with the ultra frequency, you can have 48 and 70 megahertz probe. Especially the 70 megahertz probe is is expanding a lot the images. You have a focal resolution of around 30 micrometers. So we think, or maybe this technology can be comparable to histology. And because lymphatic channel is in a secondary lymphedema undergo this kind of progressive degeneration, we actually compared the ultra frequency findings preoperatively and intraoperatively with the histology. So we cut a piece of lymphatic channel before the anastomosis and we sent to histology. And actually we found that the ultra frequency ultrasound can give us even histologic information, the amount of degeneration of lymphatic channel, because we can visualize the thickness of the wall, and we can visualize the lumen of the lymphatic channel. And you can see on the left, when we have an ectasic channel, we have a very thin wall with a very large lumen, more misshapen lumen. Whereas when we have contractile or even sclerotic channel, we can see this hyperechoic wall and a more roundy lumen in contractile type, but almost no lumen or no lumen at all in a sclerotic type. And we don't want to select this kind of not working channels to perform our LVA. So this is another information that you get from the ultra frequency ultrasound. So this ultrasound may expand further the visualization ability. Even we use it for intraoperative imaging of lymphatic vessel during surgery. Nowadays, we are doing less and less of this because we will do the selection before. But sometimes when we found at the beginning, when we found more than one channel in the same incision, we also can select the channel based on the ultra frequency ultrasound done intraoperatively. So about recipient venule, this is another important topic. When you find your lymphatic channel, you want to have a good vein where to perform the lymphatic venous anastomosis. And again, the key is to find a vein nearby lymphatic channel with a good caliber match, no reflux and in favorable position. And again, vein visualizer is a technology that has the same basis of the ICG is an infrared-based technology, but has limited application because of the depth penetrance and because you don't have dynamic information. But of course, ultrasound is very powerful in detecting vein. We know from radiologists that you can study very well all the superficial and deep venous system. So you can really expand your knowledge also about recipient venule by ultrasound, and you can have all the information that you need if you have a vein, if you need to do other plans, the location, dimension, the flow dynamics, and you can see the high fidelity planning. So this is marked on the skin before surgery, and then we open, and we already know that we will find this kind of vein with this caliber in that position. So actually, the concept here is to perform the surgery before surgery. So when you are doing the planning, you are actually performing a virtual surgery, and you will go in the operating room and you will already know what you are going to do, how many incision, how many LVA per incision, which are the possible difficulty that you may find in your incision. And this is very good, not only for your own organization, but also for telling to the patient what you are going to expect during the surgery. And even for the organization, you know that this patient will need 2, 3, 4 hour surgery. This other patient will need maybe 1 hour surgery. So you can plan accordingly also your procedure and make this procedure much more efficient also for either for the patient, either for the system. So again, the vein is very important. So we did this study in 2017, where we found that the vein is an independent factor on the outcomes of lymphatic venous anastomosis. But later on, we kind of made a kind of algorithm in recipient venule selection. And the simple concept is that you will not cut your lymphatic channel until you are not sure about your vein. You don't want to create another obstruction with your anastomosis. So you should use a lot of, mental process in selecting the vein, and even be prepared for eventual plan B, like venal rerouting or venal grafts, or dissecting the branch, or even valvuloplasty. So different type of procedure should be adapted if you are in a situation where you don't have a good vein nearby your lymphatic channel. And this situation is actually very rare. It's not impossible, because of course sometimes ultrasound can give you some little surprise as well. But usually when you have a doubt, you should already plan another procedure to bring your vein toward your lymphatic channel. Choose another way. So ultrasound enable intraoperative evaluation of lymphatic channels, as I said before, and these are some images and some video of ectatic channel on the left and sclerotic channel on the right. Also allows to plan a LVA in nodine allergy patient. Can you hear? With contraindication to ICG lymphography, but also expand a lot of creativity. So this 3 video, you can see we can plan the ELVA with ultrasound in a very precise way, and we can perform the venal rerouting method, as I was mentioning before. But even a new finding is finding the confluence point, so you can, find where lymphatic channels are merging, and then performing one anastomosis that is actually made of 4 channels that are merging into one. And this confluence point is actually not only functional, not only anatomical, but even functional point, because at that point you can see sometimes you see degeneration after the confluence. So you are making really anastomosis at the very last point. And LVA are effective also for advanced stage lymphedema. There are different papers, one from Johnson Young, one from JP, one from us. So we found that in our case, around more than 50% of the patient with advanced lymphedema should undergo lymphatic venous anastomosis, because they still have functional lymphatic channel. And actually, this patient, when they have functional lymphatic channel, they have very big channels. So it's even not anymore super microsurgical LVA, and you can really get amazing results. But still, around 30% of these advanced patients has severe degeneration. But you can offer to your patient with only LVA these kind of results that you can eventually improve if the patient asks with debulking using liposuction or other procedure. But this is functional result, and you can appreciate how LVA can really make a difference, a huge difference with the minimal invasive procedure. And again, the key is the ability to find lymphatic channel also when conventional techniques cannot. But ultrasound can be used, of course, very well in flaps, in any kind of flaps, from traditional flaps to see and check the main pedicle for evaluating the recipient site, but for perforator flaps, and of course also for lymphatic flaps. For lymphatic flaps, it gives you extra information about your lymph node, if they are normotrophic, if they are hypertrophic, which kind of vascularization they have, especially in the groin area, which is a watershed area. Sometimes your lymph nodes are nourished by the superficial epigastric, but mostly of the time from the superficial circumflex. And you know this very well by performing ultrasound before you select your recipient site. You already know where you are going to hook your anastomosis. And this helps a lot, even in designing lymphatic flaps according to the list. So according to the list concept from Takumi, any perforator flaps can be designed according to its lymph axiality and should be used according to this design, for example, in limb reconstruction. And ultrasound allows you, guide you in choosing the plane of elevation, so you can, adapt and decide before surgery the thickness of your flaps. And to do so, you need to know the type of perforator. This really helps in making the dissection faster. And so if you elevate your flap, on top of the scarpa fascia is a thin flap. If you elevate your flap on top of the superficial fascia is a super thin flap, or even a pure skin perforator. So the ultra frequency is really a game changer in lymphatic surgery. And there are so many applications for different procedures. It really expands the knowledge, improves the outcomes, it reduces the morbidity, and increase the safety and reliability. So is effective and efficient, allows a reliable and predictable surgery. Each incision is efficient and shorter. It reduces the cost because it reduces and make more predictable the OR time, and it expand LVA indication even to more advanced cases. And of course, the limitation is to perform it properly and in a timely manner. So this will be published soon. It's a book on LVA. So for those who are interested, this will come soon. And thank you again very much for your invitation and your attention.
Okay. Thank you, Giuseppe, for your amazing talk. Does anyone have a question for Dr. Visconti? I do have a question. I wanted one you already answered, if you used the intraoperative, the ultrasound, which I think you answered, because sometimes things happen and maybe the vein has reflux or something, and you have to come with another idea. So I think you answered that. And I wanted to ask you, because sometimes, and this happened to us several times, you found you have an ACG, you see a lymphatic, you also with the ultrasound see one lymphatic, and then when you perform the surgery, it's two lymphatics or three that they are joined like a shotgun, and then you only have one vein. What do you do in these situations if you want to anastomose both of the lymphatics?
So usually I try not to be in this situation. So
okay.
Yeah, so with ultrasound, you can see that under a linear pattern, maybe you have two channels, especially these usually they confluence and they merge in one channel. So with ultrasound, you can really choose the point of confluence, and it means that you will find finally one channel to anastomose, but this one single channel is made of three channels that are merging together. And ultrasound really helps because it's really a matter of centimeters. So you make an incision here, maybe 3 centimeter or 4 centimeter up. There is the merging point, and if you don't plan it, you actually lose it. And finally, maybe you will do, 3 anastomosis to a single vein with reflux. So actually, you are making a lot of efforts. So probably your anastomosis will not work very well because of the different configuration. But you could have done a simpler and more efficient anastomosis just by cutting above. So that's why ultrasound really makes things different.
Okay, so thank you. Again, thank you for for coming today to our department to do this amazing presentation, and we hope you enjoy there in Holland. Okay.
Thank you very much.
Thank you.
Sorry that I cannot follow. I cannot follow your presentation because at 9 I will have the starting of the course. But I wish you a great day and hope to see you soon.
Okay. Thank you.
Yes.
Bye, Giuseppe. Bye.
Goodbye. Thank you. Goodbye.